Next, the voice of your patient. So the voice of your patient will depend on the strength of the vocal cords, as you see here, like curtains. So the curtains pull and close normally. Okay, if there is some form of paralysis, one of the curtains is left closed, while only one curtain opens. This means this vocal cord right here is paralyzed. But if both curtains never opened, that means both vocal cords are paralyzed. So in this case, if it's paralyzed on one side, knowing that the cortical bulbar tracts are 50-50, it is most likely that this is a peripheral nerve type of lesion going to the vocal cords. So there's a problem in the branches of the vagus nerve, like for example that thyroid surgery example I showed earlier. If you have an abnormal gag, which is subserved by your ambiguous nucleus, which is also a bilaterally innervated function using the 50-50 rule. So it depends on what you find. If it's an upper motor neuron problem, you still have a backup supply from the ipsilateral projections. So if ever it was paralyzed, it will stay paralyzed only for a short while and eventually recover, because you have a backup power supply, if you will. But if the problem is peripheral, meaning it's involving the lower motor neuron at the level of the medulla, like for example a pica or posterior inferior cerebellar artery stroke, you damage the nucleus ambiguus and you abolish the gag reflex, abolish the swallowing reflex, and you have a paralysis of the vocal cords in that case. So that's a peripheral type lesion in relation to the nucleus ambiguus. Same thing when your palatal rise is not symmetrical. So normally they would go up at the same time. But what if one side of the palate does not go as high when you say ah? And knowing that there is bilateral innervation, then you need to check which one is it. So if it's an upper motor neuron lesion and you know that there's a 50% backup supply available, it will only be a slight weakness, if ever, and it usually will not last for a long time. Okay, and you check this with your tongue depressor and check if the gag reflex is intact. And in this case, there's still a gag reflex. So this is an upper motor neuron lesion. And if it happens to be bilateral, the gag reflex may actually be even hyperactive. Okay, what if it's a lower motor neuron lesion, meaning a lesion at the nucleus ambiguus or in the vagus nerve itself? On palatal elevation, when saying ah, it lags. And when you check the gag reflex, it still lags or barely moves, and that tells you that's a lower motor neuron lesion. Okay, that's the basis for using the gag reflex as a way of telling whether it's lower motor neuron or upper motor neuron lesion. Okay, the absent gag can be either a problem when you can't feel it, meaning the sensory part is affected, or it's paralyzed on that side. So the drooping on one side on saying ah and a poor gag reflex. So absent gag can be either sensory, meaning it wasn't felt at all, or it's a motor problem as illustrated earlier. Alright, so that's checking the integrity of the medulla. Okay.